What's going on, guys? My name is Muhammad, and I'm presenting a case on bleeding into an ileostomy bag. And I'm presenting this on behalf of Dr. Mitchell from Henry Ford Department of Interventional Radiology. So, my case is on an elderly male patient who presented to the emergency department for recurrent bleeding into his stoma bag. And so he had an ileostomy and was presenting to the hospital multiple times in the past few months with recurrent bright red blood that was filling his ostomy bag to a point where he was requiring transfusions. So this particular time he came in with a hemoglobin of 4 and required transfusions. His significant past medical history included a history of alcoholic cirrhosis, which had been complicated by esophageal varices, portal hepatic gastropathy, and hepatic encephalopathy. Patient also had to have a right hemicolectomy in the past and had a right lower quadrant ileostomy in place. On exam, the patient's stoma site was pink, healthy, and no evidence of like ulcerations or ischemia. Abdominal exam was also benign. And then significant labs, most significant lab was a hemoglobin of 4. So for differential diagnoses, a patient like this, given their history and their presentation, obviously you're thinking about a GI bleed, but trying to localize the source. You think about a possible lower GI bleed, given that there's bright red blood filling the ostomy. You think about some sort of bleeding, maybe from the ileostomy, from the ileum, or anywhere in the lower GI tract. Patient has a history of alcoholic cirrhosis, so you also think about things like bleeding from due to portal hypertensive gastropathy, bleeding due to esophageal varices, and then the patient has cirrhosis with an ileostomy, so you think about peristomal varices as well. That's something you would add to the differentials. So prior workup, like I mentioned, this patient had been coming to the hospital with the same complaint for the past few months. He had a lot of scopes done by GI. As we can see, some of the significant findings here. The first time around when he had the EGD, we seen portal hypertensive gastropathy with some active oozing at that time. Second time he had an EGD 2 months later. Again, you saw the gastropathy with some oozing, and then we also saw some non-bleeding large esophageal varices. At that time, he also had an ileoscopy, and the ileoscopy showed no significant findings in the ileum. It was normal. There was no source of bleeding. These images right here are the ileum. You can see that it looks completely normal. And then the following month, presented again. At that time, he had a CT angiography with a GI protocol, and there was no source or no evidence of active GI bleed at that time. So right here are some of the images from the GI angiography. Right here you can see and this is the diagnosis. The patient was ultimately diagnosed with peristomal varices. So right here we can see the right lower quadrant within the blue circle, which shows varices right around the stoma site. So IR was consulted for this patient. They ended up doing an angiography, and if we follow the images here, we access the SMV, so the superior mesenteric vein, and what we seen was a varice that was connecting the SMV with systemic flow in the common femoral vein. So in this picture, in the rightmost picture, we can see a connection between the SMV and the common femoral vein on the right. So the decision here was made to go ahead and embolize using gel foam and coils. So especially if we look at the picture in the rightmost picture, and also like the middle picture, we can see the coils and gel foam in place. And after shooting contrast, we can see that the connection between the systemic and portal system is no longer in place. We no longer see the connection between the SMV and the common femoral vein. So for discussion, as we know, varices are enlarged veins that that create a connection between the portal and systemic circulations. When a patient has liver disease, portal system is usually high pressure, and the systemic circulation is the low pressure connection. Peristomal varices are actually relatively common in patients who have liver disease. So like about 5% of the patients with liver disease, and like a stomach will have 5% of them can be seen with peristomal varices. And the standard for diagnoses is a mesenteric angiography, and you look at the venous phase. So in regards to management, it's continuing to develop and evolve. Initially, local measures were the most popular. So things like putting in sutures, using drugs like propranolol, holding pressure. But now they're more sort of like a temporary solution. And so in our patient, we did put in sutures, we did try propranolol, we did hold pressure, but those were all temporary solutions until we could find a better solution or more long-lasting solution. So recent focus has been on addressing the underlying pathology, and a lot of the literature out there, although limited, is focusing on the effectiveness of TIPS, because TIPS goes ahead and addresses the underlying variceal development, right? For us, our patient was not a candidate for TIPS because of their history of hepatic encephalopathy. So you look at other options like embolization, sclerotherapy. Those do have a little bit higher chance of rebleeding when compared to TIPS, but if TIPS is not an option, then they become good options as well, or they become options that we consider. As we've seen, they had the history of hepatic encephalopathy, so ended up not being a candidate for TIPS. And then, like as I mentioned, we did use local interventions, but those were just temporary measures, and we kept on seeing rebleeding with them as well. So we ended up deciding to go ahead and proceed with embolization therapy. And so we ended up, like we've seen in the images, accessing the SMV and throwing in some coils and gel foam to treat the variceal connection. And as we've seen in the images, after throwing in the gel foam and the coils, we no longer saw the connection between the portal system and the systemic system. So here are the references. This was the interesting case to me because I had never heard of peristomal varices prior to this as a med student. And also, like at Henry Ford, it's a huge liver center, and we see a lot of patients that have liver disease and also like stomas in place. And so peristomal varices is something that's relatively common in these patients and something that should always be in our list of differentials when we're addressing a bleed in a patient like this. So thank you for your time, and thank you for listening to my case.